Dear colleagues, we're coming back for the second part of the seminar on pediatric pulmonary hypertension with an highlight on clinical science using the literature review of 2019 and early 20. You know all this treatment algorithm that allows you to treat the patients. So patients should be seen in an expert centers, be considered for general treatments, do the acute vasoreactivity testing, and as I told you in the first part of the seminar, treated with CCBs, and clearly be followed up to see if there is sustained reactivity. If the patient is negative to acute reactivity testing, you base your decision on the high and low risk patients. Low risk patients can be treated with monotherapy, but now most expert centers will start with upfront combination therapy. In the high risk patients, not only early combination is useful, but the use of IV or sub-Q prostacyclin is considered. It is essential to do serial reassessment, and then depending on the outcome, you have access to non-medical treatment such as atrial septostomy, POTS, and lung transplant. For the treatment, I already showed you this table coming from the publication of the symposium with EMA and FDA, and you see that we're using still a lot of off-label drugs, which is not without risks. And as you can see on this very nice publication coming from the US, it is not without risk. There can be adverse events when you use these drugs. So clearly pharmacovigilance is useful. And you must remember also that when you use off-label drugs, you may not have indeed any idea of what is the right amount of drug that you should deliver to these patients, as for some of these drugs, the PK/PD studies are still ongoing, and you may indeed not use the right amount of drug and induce adverse events for inadequate use or having no effect because you don't use enough of these drugs. So what are the studies that are indeed ongoing and we are awaiting results? The tadalafil study is finished and discussed with the authorities, and we may have a publication in the next future. And Brisentan is discussed at the European Medical Association. The publication is ready for submission. There is 2 ongoing studies with macitentan and selexipag, and a few studies still ongoing also with treprostinil, either oral or IV. Tadalafil, there has already been a publication on the pharmacokinetics and safety with this particular drug, and you can have access to that in the British Journal of Pharmacology in 2019. So you will see that doses of 20 and 40 milligram are something that can be used also in pediatric age. We wait the full publications in the next few months. Oral treprostinil is an oral prostacyclin. That's something everybody would like to have. There is a few publications from in particular the US on the use of oral treprostinil. It's still not approved. There is still ongoing studies that may be something interesting in the future, but I'm not convinced that we will have access to this drug easily in Europe. Non-medical treatment, and clearly the POTS shunt has gained interest over the last few years. We're currently running a study inside the top registry to have an idea of top indication of POTS indication as well as outcome, and so we may have a little bit more data on that by the end of the year. But this interesting paper from Rosenzweig from New York shows that you can also I would say, put valve pots or unidirectional valve shunt that allows only a right to left shunt through the pots that enlarge indeed potentially the indication. As you know that basically you would think to do a POTS in patients with suprasystemic pressure, but with this approach that may change a little bit. Discussing non-medical treatment, I was interested by two publications on use of ECMO support in these patients. You remember that maybe 10-15 years ago we would not have discussed ECMO for this population. Now it seems that ECMO as a bridge to transplant, or even as a bridge to full treatment with triple combination therapy, is something that can indeed be done in experienced hands. And so you must not exclude completely from the therapeutic approach ECMO to support the patients for some period of times. I like this paper from Tom Kulik that discuss an approach that was indeed done many years ago, which is in congenital heart defect with a pulmonary overcirculation but considered non-operable, to indeed put a pulmonary artery band and then potentially treat these patients with some of these new drugs. And the results basically are a bit disappointing with this approach. Maybe there is very few patients and it's difficult to really extrapolate from these results. But there is still some work to do to see if this potential treat and repair approach is really feasible and without risks. I cannot avoid to discuss the FUEL study. The FUEL study is the trial using a phosphodiesterase 5 inhibitor, udenafil, in patients with Fontan physiology of cardiopulmonary anastomosis or univentricular heart. And this paper was published in 2018, just showing what was indeed the design and the rationale for the study. But we had at the end of 2019 the first result with this trial, and it was published in Circulation. Treatment with udenafil was indeed not associated with an improvement in oxygen consumption at peak exercise, which was the primary endpoint of the study, but some other parameters of exercise testing were improved. There were also other improvement in some other parameters. Clearly the drug was quite well accepted with very few side effects finally, but basically the study has to be considered as negative with the primary endpoint, and we need to work on how we should probably investigate drugs in this particular population. And based on this, the editorial of Mark Gevelig in Circulation is extremely interesting, and I think all of you should read it. The conclusion are that it's extremely challenging to study Fontan patients, and maybe that most of the work should be done in advance before doing the cardiopulmonary anastomosis, and that treatment after that are a little bit more difficult to address. So should we aim at treating the pulmonary vascular bed, the ventricle per se, or indeed the systemic bed? This is really something we should discuss in the future. The last part of this presentation is on risk factor in patients with PH. So I start with some very interesting adults, and a few registries have been assessed to look at the risk factors and do some studies about that. So the REVEAL study in the US, the French PH registry, the Compera in the German-speaking countries mainly, and the Swedish PH registry. So this is how it was done in Reveal, Spar, Compera, and FPHN. Multiple variables were used. You see that the Reveal used 12, Spar 8, Compera 8, and French one only 4. They were using most of the different forms of PAH. The French was aiming mainly at idiopathic irritable and scleroderma. A methodology was a sort of score or grades, or if you can reach low risk variable for the French one. And there was an external validation. So this is represented in this different survival or event curves. And you see that as soon as you reach a low score or a low risk group, which is the green line, you have clearly a better outcome. And if you compare with the high risk red line, I mean, the difference is quite significant. So clearly when you treat the patient, you should aim at put the patient in the low risk or low grade risk score to expect a better outcome. And you can see that again in something that is a bit different on the right panel, which is once you can move a patient from, I would say, the red line to the green line by changing his score with treatment, you improve clearly the outcome. So the aim is clearly to go to the green column. So maybe the green column is not the same for everybody, or it's not used the same, but as you can see, this is for the adults, and you know that we can use indeed this different parameters also in the pediatric population based on the different guidelines that I presented you in the first part of this webinar. So you see, for example, in Bologna, and this paper was presented at DSC in 18, and paper was not published in 19, but I'm sure it will come. So you see that at baseline, patients are in this green column, but if on follow-up, and that's the dotted lines, you can move this patient, you can really improve the patient, and especially the improve to low, which is the green dotted line. You see that if you move from one line to the other, you can expect a clear improvement. In pediatrics, you have this table. So is this table, I would say, in predictor of outcome of pediatric PH, you can have something that is really helpful. In pediatrics, we can probably report consistently functional class. NT-proBNP, now we have a few papers, some hemodynamic parameters. Clearly, I showed you that acute vasodilator response is something that is important, because if you're a vasoreactive patient, your outcome is much better. This does not mean that the paper from Plogstra shows that you cannot use other variables, but at least it opens something interesting. We have tried in the registry to see if there were indeed some of those parameters that are useful. The study was designed indeed to do some disease progression composite outcome endpoints, but there were some very interesting results that came from that. So basically, we decided to use 3 disease progression definition and see how many events we had indeed in the top registry over time. But at the end, what comes out is that we may use that as indeed factors that define risk. So you see the analysis here, and the analysis is showing that there is independent risk factors for long-term outcome. There were functional class deterioration, which comes in most of the studies, hospitalization due to a pH deterioration, and pH worsening based on some specific clinical assessments that were indeed recorded in the top registry. So clearly they were shown to be a problem, and you see on the particular slide that one of the main problem is hospitalization. So clearly hospitalization is a risk factor. If your patient is hospitalized for pH deterioration, which this means that he is at higher risk of death or transplantation. And deterioration of functional class is the second one. The pH worsening is probably not as important, but clearly these parameters are extremely helpful when you follow these patients. This was assessed by the group of Berger in Groningen and published by Harman. And you see, to finish a couple of slides on the bronchopulmonary dysplasia, 71 publications. A lot of work on echo, RV function, BNP, some on CAT and some on protocols. I will show you only a few of this paper. Risk assessment and monitoring of chronic pulmonary hypertension in premature infants. This is a workshop, very interesting paper, a lot of data, and you see that echo is clearly extremely good for screening in this very particular population. Cardiac catheterization should be considered in some of the patients. We can use CT, we can use MR. I think these patients need also expert groups to assess pulmonary hypertension, and especially to treat, if needed, to be treated this increase in PA pressures. So at the end of these seminars, you have understood that there is a few take-home message. Genetic and phenotype is making progress. We need to standardize the workup for all this group of patients. Over the second part of this seminar, you've seen that there is still a lot of work to use treatment in pediatrics and improve treatment approaches. There is still too much off-label use. We need to improve the risk assessment and to treat patients. This is important for the follow-up, to really adapt treatment on your patient evaluation and evolution, and be quite aggressive. And some subgroups, not only BPD but a lot of other ones, are extremely useful. And I thank you for your attention.